All right, let's talk about one of the most high-stakes situations you'll face in medicine, the acute abdomen. We're going to break down a simple, repeatable framework you can use every single time to spot a surgical emergency and, most importantly, act fast. Okay, let's get right into it.
So first off, what are we even talking about here? An acute abdomen isn't just a bad stomach ache. We're talking about sudden, really severe abdominal pain that could actually be life-threatening. And here's the kicker, it might require emergency surgery, and that's why having a system is so critical.
To make this all feel a bit more real, let's walk through a case together. Picture this. A 52-year-old man comes in, he tells you he was just fine, and then bam, 4 hours ago he was hit with this sudden severe pain right in the middle of his belly. This is where your work begins.
Okay, let's get his vitals up. His pulse is racing at 110. His blood pressure is way down at 95/60. He's got a fever. On top of that, he's vomiting, and he tells you he hasn't passed any gas. Look, these aren't just numbers on a screen. These are massive red flags screaming that something is seriously wrong.
So with a patient this sick, where do you even start? You always go back to basics. That's your primary survey. This whole step is about one thing, finding and fixing what's going to kill this patient in the next few minutes before you do anything else. And you know what that means. We're running through the ABCs. A is his airway open, B is his breathing okay, and C, the big one in this case, what does his circulation look like? Is he in shock? This quick check makes sure the patient is stable enough for you to even think about what to do next.
Let's just zoom in on that blood pressure for a second. 95/60, that is dangerously low. When you see a low BP with a fast heart rate, that is the textbook definition of shock. It means his vital organs aren't getting enough blood flow, and that's a fire you have to put out immediately.
Now, our patient's unstable vitals are just one of several critical red flags. If you see any of these things, a rock-hard, rigid abdomen, signs of widespread inflammation, or you even have a whiff of suspicion of something catastrophic like a ruptured aneurysm, the game completely changes. You stop investigating, you start resuscitating, and you call a surgeon immediately.
Okay, so let's say the patient is being stabilized, fluids are running, the team is working. Now your role shifts. Now you get to put on your detective hat and start gathering the clues you need from the patient's story and a physical exam.
Just asking about how the pain started can tell you so much. Our patient's pain was sudden, a real thunderclap. That immediately points you away from slower things like an infection and toward a disaster. Something perforated, something ruptured, or a major blood vessel got blocked.
And what about the type of pain? Is it colicky? Coming and going in waves? That makes you think of a blockage, like a kidney stone or a bowel obstruction. But our patient's pain is constant and severe. It's unrelenting. That again points towards something much more sinister, like tissue that's dying from lack of blood flow.
This brings us to a phrase you need to burn into your memory. If your patient is writhing in what looks like 10 out of 10 agony, but when you gently press on their belly it feels surprisingly soft, you have to think about mesenteric ischemia, a blocked artery to the gut. It's a true killer and a diagnosis you just cannot afford to miss.
So during your exam, you're going to look, listen, and feel. You're looking for distension, listening for bowel sounds, but the real money is in finding signs of peritonism. That's when the abdomen is rigid and the patient has what we call rebound tenderness. If you find that, you've pretty much found your ticket to the operating room.
Okay, you've got a story, you've got your exam findings, now it's time to bring in the heavy artillery, the investigations that will help you confirm what you're thinking and build a solid case.
And you can start getting critical data without even leaving the room. An ECG is a must because sometimes a heart attack can show up as abdominal pain. And a quick bedside ultrasound, it's a total game changer. You can look for internal bleeding, check the aorta, or see if the gallbladder is the culprit, all in a matter of minutes.
Next up, urgent blood work. You're going to send the usual panel for sure, but if there's one test I want you to really focus on here, it is the lactate. A high lactate level is a massive warning sign. It's telling you that somewhere in the body, tissues are starved for oxygen, which is exactly what happens in bad sepsis or ischemia.
Now, this is a big if. If your patient is stable enough for a trip to the scanner. The absolute gold standard for figuring out what's going on is a CT scan of the abdomen and pelvis with contrast. It gives you that beautiful, detailed roadmap of everything inside so you can pinpoint the problem.
All right, let's pull it all together. You've assessed, you've investigated, and you have a very strong suspicion about what's happening. Now it's go time.
It's time to shift from thinking to doing and finalizing the plan.
Now, in reality, you should have been doing all this from the moment the patient hit the door, getting 2 big IVs in, pouring in fluids to treat the shock, keeping them from eating, getting their pain under control, and if you suspect an infection, you're starting broad-spectrum antibiotics. But maybe the most important step, calling your surgical colleagues early. Do not wait.
And this brings us to the ultimate question, doesn't it? The question this entire process has been building towards. After all this work, what are the diagnoses that mean this patient goes to the operating room right now?
Here it is. This is the list of killers. A hole in the gut, a piece of bowel that's twisted and dying, a ruptured aneurysm, a ruptured ectopic pregnancy, or just widespread peritonitis for any reason. If you diagnose any of these, there's no debate. They need surgery, and they need it now.
So let's just boil this all down into one simple framework you can take with you. 1. Assess the ABCs and spot those red flags. 2. Take a focused history. 3. Do a targeted exam. 4. Get your urgent labs and imaging. And 5. The most important part, resuscitate and call surgery early.
I want to leave you with one final thought, a really tough but important question. What do you do when you don't have a clear diagnosis, but you can see your patient getting sicker right in front of your eyes? The answer is the core principle we've been talking about this whole time. You call surgery. Because sometimes the only way to find the answer is in the operating room.